well, feel free to ask me any question after the presentation. Well, thank you very much for the presentation. As you already said, I'm the head of the unit of congenital heart surgery in the Children's Hospital of Buenos Aires, Dr. Pedro de Lizalde, and I'm also the Chief Scientific Officer at Avatar Medtech, and I will explain that a bit later. So, as you know, aortic valve surgery in pediatric patients is essentially a palliative procedure by now. Hopefully, in some days, it will be some.
Sorry to interrupt you, Dr. Lugones, but I don't think we are seeing your screen yet.
Oh, okay.
Could you share it again?
Okay, I'm sharing the screen. Yeah. What happens? I will stop sharing.
Yeah, I think so.
And share it again. It says something. Okay, now I can share.
Yeah, now we can see it.
Can you see it
Thank
now?
you.
Okay, yeah, it's something related to that. Okay, let's start again. So, well, as you know, aortic valve surgery is a palliative procedure. Our main objectives in this procedure is to keep the patient alive, mainly, and in the long term, to try to reduce the number of interventions and the quality of the interventions during time. So another big issue is to avoid anticoagulation. Remember, kids are not adults, and we have to take care of them very well. And they usually, if they are under anticoagulation, they cannot play and live a normal life. A very big issue is also to preserve the left ventricular function, and even more important is to allow the aortic annulus to grow in time. So, as you can imagine, the choice that you make at the time of the first operation will have a lifelong impact. So, Dr. Konstantinov, some years ago, made a very nice description of what the ideal valve, aortic valve surgery in children must be. And he defined it to, as the result of the operation, we should have an unobstructed, competent aortic valve that is also durable and accommodates growth of the child. These are key features. Of course, this valve should emulate the native aortic valve and preferably use autologous tissue with growth potential. So, but so far, as you know, that we have today, and you know all of them, of course, and you know that mechanical valve replacement has several issues, as the other entities also have. For example, if we go to the mechanical EVR, we know that it does not adapt to the patient's growth. That is the reason why companies do not manufacture these small valves, because it does not make sense. And that is the reason why we lack these small mechanical prostheses. It is very important that if we use, let's say, a 17 millimeters or 16 millimeters in diameter valve, we stop the growth of the annulus, and the patient with time will become really a nightmare during the operation. So, and of course, these patients need anticoagulation, which is not good, as I recently said, and they can suffer from pannus ingrowth and thrombosis. The Ross procedure is a good alternative, although it has a long learning curve, and there is a need for intervention on the autograft and the homograft. Then we have the valvuloplasty, which it is somewhat, it's kind of an art and depends really a lot on the underlying anatomy of the patient and on the surgeon's expertise. So that is, it has the problem that it is difficult to reproduce. The best hands produce the best results. Then we also have the bioprosthesis, which, like the mechanical prosthesis, stop the annular growth because they have a rigid frame. They do not adapt to the patient's growth, and of course, they are not manufactured in small sizes. These valves, with time, suffer from structural valve deterioration, and that is a big problem because many of them only last for a few years in these patients. Homographs are not really used because they show high mortality in pediatric patients. And of course, they have the other problems. And we also have the Osaki procedure. But the Osaki procedure is, first, it is because designed for adults. So it does not take into consideration the patient's growth. So that is very important. But at the same time, it is a leaflet by leaflet replacement. What does that mean? That means that we measure the intercommissural distance, and then we replace that leaflet with a new leaflet of the same size. So the problem with that is that if we have an asymmetric valve, okay, we will end up having again an asymmetric valve. And the end of the spectrum is when we have a bicuspid valve. So at that moment we start the method starts to be more inaccurate. Also, some other problems of this procedure is that they do take non-physiological measurements. That is, the root is open, and then we measure the intercommissural distances. So the heart is relaxed, and it is not really physiological. We are not measuring the dimensions of the aortic root with a heart filled with blood. Also, as we have to evaluate the valve during the aortic gross clamping time, we have to measure with the heart open. It takes us a lot of time to manufacture the leaflets and then implant them in the correct position. And of course, as you know, the devices that the AV Neo has are simple templates with which we cut the leaflets. And these devices, of course, do not assist in the implantation procedure. So all these techniques are really very good for special cases, but there is no really one single solution. And when we have too many options, this means that, well, none of them is really very good. So what I think is that the ideal aortic valve operation has to take into consideration the definition that Dr. Constantinou once said, but also we have to take into consideration the method, because the definition that was explained in that article is only about the valve. It says it must result in a valve with these features, but we are not taking into consideration the method. And the method has to be, most of all, it should be reproducible. Of course, it has to be effective. And if it is fast and simple or intuitive, that could be really a very good idea. So we need solution, or at least we need a better option, or at least we need one more weapon in the armamentarium. So several years ago, we started thinking of a concept that is the reconstruction of the root that we call avatar.
Dr. Lugones, sorry for interrupting again. I think now you should be maybe able to start your webcam.
Okay, I will try now. Yes, I can see. Great, thank you very much. I continue. So, as I was telling you, we have come with this idea we call avatar. It is from the phrase or the definition of aortic valve trileaflet autologous reconstruction. Mainly, the concept is a reconstruction of the root, which is very different from a leaflet by leaflet replacement. We take into consideration the whole root, and we design a valve that is always symmetric. We can do that for any kind of native valve because we do not take into consideration the morphology of the native valve. That is, the Osaki method takes into consideration the sizes of each of the leaflets, but we remove completely, as I will explain later, we remove the aortic valve, the native valve, and we replace it with a new valve that does not have the influence of the native one, let's say. At the same time, we have developed a concept which we call oversizing, which is has the ability or gives the valve the ability to accommodate to the patient's growth. So we are designing this for the pediatric population, not for adults. And when it comes to the application, we have developed some ways in order to make the measurements that define the size of the valve that we will implant by physiological means. Okay. We built the new leaflets before the aortic cross clamping because the measurements that we take rely mainly on the echo, so the heart is filled with blood and working. And then we have gone beyond, and we have designed, or we are currently designing, devices that can assist during the implantation procedure to make it easier and more reproducible. So this started back in 2016. We had an idea. I have the blessing of having a brother who is a physicist and understands a lot of the math and the geometry behind anything. So we came with an idea, and then we follow this pathway until we get to the application in humans. And I will try to tell you a bit about this story in a few minutes. All started with this paper and pencil, making a lot of calculations. My brother was a very important part of this. And we end up having the morphology of the valve, and we understood how it should work in the real body. So we started trying to emulate that with simple things that we have at home. And then, as you can see in this video, we ended up having a valve that was competent during closure. We use, as you can see, toilet paper and many other things we had at home. And then we thought that it would be great to put everything, all the calculations into a computer. So my brother, who is very skilled in this, so he ended up having a model, a computer model that could allow us to have the proper morphology of the leaflets and the arrangements of the sinuses of Valsalva inside the aortic root. And when we compared that with the normal aortic root, we saw that this model seemed to fit properly inside the root of the aorta. So after that, we said, okay, we need some measurements. We need some devices that can tell us where to locate the valve and how the implantation line should be, and which the sizes of these leaflets should be in relation to the size of the aortic root. And then we started making the digital models and printing some prototypes. This is a very interesting technique. Additive manufacturing helps us a lot in daily innovation. Then we attracted the interest from the Aarhus University, and we started the collaboration. There you can see me with Lisa Carlson-Hanse. I went to Denmark, and we tested our design in vitro in the cave lab in the Aarhus University. And what we did is mainly we took native pulmonary roots and we used this heart simulator. As you can see, this machine has a pump and has all the chambers of the heart, and this is a circular circuit. So we could interpose the root of the pig and test it. First, we tested at rest, and then we tested simulating exercise at 7 liters per minute. And we evaluated the valve by means of several issues. We measured it by echo. We used an HD camera, high-speed camera, and then we also make some hemodynamical measurements. Then we removed the native valve, we performed our operation, and we mounted again the new leaflet. So we evaluated by this means, as I told you before, and what we found is a valve that really worked very nicely. We managed to make it, when we took the pictures of the valve, we realized that they look pretty much the same as the normal leaflet. And probably you are taking a look and you're wondering which one is which. So if you take a closer look, you will see that the valve in the left has these lines which represent the collagen bridges that the normal leaflets have. Of course, the arrangement, the histological arrangement of these leaflets is magnificent. It has millions of years of evolution. We cannot do that. We cannot emulate that histology with a simple piece of pericardium. But anyway, the shape and the morphology and the movement of the leaflets was really very nice. And when we evaluated the features that we really wanted to have, we found that three main characteristics that this valve had really 3 points that were completely different from others. First, we found what we call a windmill shape. As you know, when the valve closes, the normal valve closes, it resembles the shape of the Mercedes-Benz. While here, we wanted to have oversized leaflets. So during closure of the valve, the shape of the closed valve was like a windmill shape. This allows for accommodation to growth. Of course, this valve was also enlarged and oversized in the height. So we ended up having an increased coaptation height, and we had a bit of prolapse, or what we call negative below the annular plane. All these features could potentially allow for accommodation during growth. When we tested them with echocardiography, we found that the valves were competent and were not showing any degree of regurgitation. And we also found no an orifice, a geometric orifice area that was normal. That was important because we were using oversized leaflets compared to the ones that the native had. So we thought that could eventually lead to crowding at the root due to excess tissue, but we didn't find any stenosis, as I will tell you later. We measured the coaptation height in these neovalves, and we realized that it was really increased, and it was an interesting feature. And also we found the negative below, as I told you before. We measured the gradient, and we found no stenosis in the neovalves when compared to the native ones. So, as a summary, we found no regurgitation, no stenosis, and these three main features in the echocardiographic evaluation. Then, encouraged by these results, we moved to the in vivo test. And again, in Denmark, we started working with this idea of doing the procedure in pigs. We had a very low-cost first proof of concept here in Argentina. We tested the valve in the pulmonary position in a pig, and we could replace it with no problem, and we found the same features that were found in the in vitro test. And when you take a closer look at the valve, you will see that the commissures are aligned, that it is symmetric, and it closes very well. It has a suction inside the right ventricle, as you can see, and the valve tends to close nicely. So we went back to Denmark, and we used 12 pigs, and we performed the operation through the midline sternotomy. We connected the patient to cardiopulmonary bypass, and then we cross-clamped the aorta. We, of course, evaluated the patient pre- and post-operatively, and we performed the procedure in the pulmonary position, measuring non-invasive hemodynamic and echocardiographic variables. We found the same key anatomic findings and the same results than the in vitro procedure. That is, the below the anular plane, the increased coaptation height, and the windmill shape. We found no important regurgitation. 10 out of 12 had no regurgitation at all, and 2 had minimal regurgitation, and we found no stenosis in any of the patients. So the results were the same. So we wonder, could this have the potential for growth accommodation without regurgitation? So in 2018, we had a patient that came to the outpatient clinic, and then we saw that the patient was in heart failure, and we proposed this to the family, and we operated on him 6 years ago. We performed the procedure, and from that moment on, the patient lived a really very good life, and that was the first case. But what we are doing now is we evaluate the patient preoperatively using transthoracic and transesophageal echocardiography. We, of course, evaluate the morphology and the opening of the native valve, and we take measurements of the different parts of the aortic root. A very important part of this evaluation is the measurement of the sinotubular junction. Why is that? Because the leaflets, the free margins of the leaflets will end up closing at that level. So we need to have the proper measurement of that area, because we will configure the valve or locate the valve in such a way that it closes perfectly, especially at that level, okay? Of course, we evaluate the regurgitation, the degree of regurgitation, and the degree of stenosis of the native valve. And then after we open the heart, we can see the valve and we remove it completely. So far, we have operated on 11 patients with a median age of 7 years and median weight of 19 kilograms with 6 previous procedures in 5 patients, as you can see. The morphologies of the valve varied a lot. And then we are working on the development of a set of medical devices. We have built a company which is called Avatar MedTech because we needed funding and we needed some engineers and 3D designers and regulatory people and many other things to try to develop a set of instruments that can help us surgeons to do the procedure in a more routine fashion, okay? So then when we replace the valve, we can find that the final result is a valve that is symmetric, and then has really a nice opening. And when we evaluate the performance of the valve after the procedure, we see the same key features that we found in the in vitro and in vivo evaluations. The negative below is an important thing because with time it tends to be reduced. We find this increased coaptation height, which also will make the procedure last, the valve last longer. And we found mild to trivial regurgitation in all the patients. As you can see, a key feature of the valve is that it is symmetric, because we do not rely on the basic morphology of the valve. We do not measure the intercommissural distance. We remove the valve completely, and then we locate the new leaflets inside the aortic root as if it was an empty cylinder, okay? And then we found no stenosis during postoperative evaluation in the short term. So when we have a patient with a native valve of any morphology, we can use this procedure taking into consideration the sinotubular junction diameter as a reference and using a set of device that is currently being developed to achieve a competent, non-stenotic, symmetric, and oversized valve made of autologous tissue and without a rigid frame. This is very important because it won't stop the growth of the annulus. So the idea is to take a patient through childhood and adolescence in order to achieve a more definitive, let's say, approach in the next operation. So, of course, you will ask me, what about the durability? The native valve is a perfect structure, as I told you before, and we cannot emulate that. And the key is the material. We think that we have found the proper arrangement in the space, that is the geometrical features of the leaflets that allow the valve to work properly. But of course, the material suffers from retraction, calcification, and anything. And of course, the material does not grow. So the durability of these valves will probably be reduced, but we need to think of that as a next step. And maybe in some years, we can find the proper tissue that lasts longer. So now, in order to avoid the retraction and the calcification caused by that appears frequently in children, we have started using autologous fresh pericardium. And as you can see, the result is very nice. You can see that the valve are also oversized, that they move nicely. And this is a patient, 6-year-old patient with severe neonatal aortic stenosis that had underwent a valvuloplasty and have severe aortic regurgitation. The annulus was 17 millimeters, and we performed the avatar procedure. And this is a picture of him 1 week after surgery. He's now after the operation. So what are the future directions? Well, we are trying to finish our devices to have a reproducible means to do the procedure. We are now exploring a collaboration with Long Island University and the SAW systems. They have what they call the Living Heart Project, which is a highly accurate, personalized digital human model, heart model, that is the digital twin of the heart. With that, we think that we can test in silico several features of the valves, and we can eventually, with time, reproduce different morphologies and find the best more arrangement for the new valves and the new devices. The FDA and other regulatory agencies are pushing forward to this because they want the digital twin to become one of the ways to reduce the animal validations, or at least the number of animals that are used, and to try to also reduce the number of patients that are enrolled in clinical trials in order to test, for example, a drug or a medical device. So hopefully we will have a collaboration, and we will be able to submit results of these new arrangements in the near future. So some take-home messages. Of course, much collective effort is needed in order to improve the quality of life and the outcomes of those patients with that need aortic valve surgery. And this approach could eventually become an alternative approach to the classical surgeries, as it results, as I told you, in a competent, non-stenotic, symmetric, and oversized valve. The valve is made of autologous tissue, but eventually could be, some other tissues could be used. And the idea is to give the valve the potential to accommodate to growth. New materials are key in this history because we need the proper histological structure to resist during the cardiac cycle, and the ability to grow will eventually be another key feature in solving this problem. And of course, many more studies are needed in order to look at the long-term performance of the valve to fully evaluate this procedure. Thank you very much.
Hola, Ignacio. Hi.
Hola.
I'm very sorry to
How are you?
communicate, to enter in the chat a little bit late, but I had some clinical problems. Well, first of all, thank you very much for, that you accepted our invitation. Is really a pleasure and an honor to have you here. And well, see
Thank you very much.
Many times. So I really appreciate your work. Your science is a very interesting, research. But I have a few questions, if possible, talking about, this technique. Well, first of all, what is the difference? Because between other proposed techniques, for replacing the cusps, like the Ozaki, for example. And what do you think about that? Some groups, for example, the Boston groups, we invited Chris Baird to give a lecture in our, in this series of international lectures. And they said that the Boston group abandoned the possibility of replacing the whole leaflet, but they consider to replace part of the leaflet, like say bicuspidalize, the aortic valves, in order to keep some anatomical feature of the native valve in order to make, the possibility of growing. What do you think about these general comments? And lastly, we have a great revival of the Ross operation, in the sense that in kids, you have no other choices to do the translocation of the root. In adults, now we reinforce the root. And this apparently, gave us great results, in the sense that you preserve the native aortic valve, preserving the valve for dilatation. Of course, you jeopardize the pulmonary valve, putting a homograft that you can replace, but also you can put some percutaneous valve in the future. So, in your opinion, is there a selection bias between maybe a Ross operation or your proposed technique for a 6-year-old kid? What do you think about that?
Well, interesting questions. And first, let me tell you that although this procedure might look very similar to the Ozaki procedure, and I always find it hard to explain the differences, there are many. As you know, the aortic valve, in order to work properly, just has to have the perfect structure and the perfect location. If we do not reproduce that native anatomy, we'll never have the proper function. First of all, there are differences in terms of the morphology of the resulting valve. The idea of replacing the leaflets is not even an idea from Dr. Ozaki. It's a very old concept. And many attempts have been done in order to try to solve that problem. The main difference is with the Ozaki procedure is that we always reconstruct a symmetric valve. The Ozaki procedure designs, as I said, a valve that can be asymmetric. And when the native valve is bicuspid, that is a huge problem because we start eyeballing. We try to accommodate the leaflets in order to look similar. So the problem with that is to rely
Cazzo. Connessione è andata?
Sì, credo abbia avuto un problema lui perché io invece la vedo bene. Magari adesso si stacca e si riattacca.
Sì.
can you hear me?
Yeah, now we can hear you. We lost for a second and ok. No, adesso l'abbiamo perso del tutto.
Ma adesso cercherà di rientrare, penso.
Sì, avrei avuto un problema.
Can you hear me?
Hey, yes. Great.
I lost you for a second.
Yeah, we always forget that you're talking us from the other side of the world, So.
Yes, indeed. No, I was saying that the difference is, I don't know if you hear me, but I will repeat that one of the main differences that lies on the morphology of the resulting valve. Okay, the idea of replacing the leaflets is not new. It is not Dr. Ozaki's idea. It is a very old concept. Okay, but the difference is that we always one of the differences is that we always reconstruct a symmetric valve. That is very important. And I don't know if you heard me, but I will repeat it. The extreme is when we have a bicuspid valve. We start eyeballing because we cannot use the intercommissural distance as a way to replace the valve, to guide the new basal attachments of the valve. So what we do is we remove completely the native valve, okay? we end up having a symmetric valve that distributes blood pressure equally in the three sinuses. Second point, the valve, the Osaki procedure as a difference is designed for adults. So it does not take into consideration the growth of the child. So if you design the valve with a certain morphology, when the patient grows, the valve will become insufficient. So we oversize the valves in order to come from this shape with windmill shape and the three features that I described. With time, the valve will become the perfect, let's say, Mercedes-Benz shape. Okay, that is in terms of the leaflet. Another difference is that we use autologous fresh tissue. That's a difference that Osaki uses the glutaraldehyde treated. There are differences in the valve, and there are also differences in the method. What we want is the Osaki procedure takes a lot of time, of aortic cross-clamping time. Why? Because you open the root, you have to remove the leaflets, you have to measure the intercommissural distances, you have to build the leaflets, and you have to manually suture them. Okay, so there are many steps in which you can either make mistakes or it will take you time. So the differences in method are that we measure the sinotubular junction before the aortic cross-clamping time. We build the leaflets with taking into consideration the oversize, and then we open the aortic root with the valve, the leaflets already done, and then we implant it in, and we are working on those devices to implant it very fast. So imagine a future in which we could eventually have a set of devices with which you can perform this operation in, I don't know, 40 minutes of aortic cross-clamping. Open the aortic root and just simply remove the valve, draw the proper locations of the leaflets, and then insert it semi-automatically. That could be good because we could eventually have a procedure, short procedure with a valve that can last a lot of time. So with that, we allow the native annulus to grow. What about the native tissue that the Boston group is talking about? Well, of course, we cannot replace the native tissue. We have no, and that probably is not, if we found the proper tissue, this will not be for a surgical meeting, that would be for the Nobel Prize. So the proper arrangement is tissue engineering, and we are taking a closer look at that, and probably we will have that, but in a couple of decades. But as you know, the native histology of the valve, of the leaflet, is very complex. It's a perfect structure. We cannot emulate that, but at least we can emulate the geometrical function of the valve. So I think that those are the main differences. It is one more leaflet construction. Yes, it is one more, and we need to prove if this will work or not. But the preliminary results are encouraging.
Okay. So I was wondering, we're doing most of the cases, complex cases. We do three-dimensional reconstruction with sometimes, 3D printing stuff, so you have the heart in your hands before starting the operation. Would be interesting maybe if you can, simulate in a 3D model your valve before the operation. So eventually you can have in your field just the right valve, maybe you have just the right valve, but maybe after simulating in the aortic root that you reconstructed 3D and printing in 3D, you can have a really more reliable thing to, also to decrease operative times. I don't know, maybe it's just the future, Anyway.
Yes, I think that will be the future. I forgot to show you a short video of a 4D flow MRI that we performed in one of the patients.
Really?
That would have been interesting to show you, but I forgot to put that video. But I think that with time, probably in a few years, we will have that tool. And that would be fantastic, not only for research purposes. Of course, we are willing to test all the different morphologies and the degree of oversizing and many of those things that we can test maybe in silico. And then we can move to a small in vitro trial or in vivo trial. But it would be great if we could join all the mechanical properties of the valve, the electrical properties, the flow, and if we could also add pressures to the system, and we could evaluate with a patient-specific tool the anatomy and the function of the valve. That would be great. Yes.
Perfect. Okay, so is any other question from the audience? Francesco, Alvise? No, I think that we are just running a little bit out of time because we don't want to steal some precious time for your day of work, because just it's morning in the Argentina, right?
It is morning here, yes.
Yeah.
Yes. Not early, but morning anyway.
Okay. So, Francesco?
So no question for me. So I was just asking about the difference between Ozaki, because it's
This is the main question, the difference between other
yeah,
and also
the question that everyone asks.
Yeah.
And it is difficult many times to answer because it has several things that need to be outlined in terms of the valve, as I told you, and the method.
Okay, so Ignacio, with the hope of seeing you in less than 1 month in Bologna,
we will.
This first, World Summit all together with the World Society, CHSS, and ECHSA. I'm thank you again for your time and for sharing with us your science and your tremendous work in the field of congenital heart disease. We are very amazed about that. So thank you very much for your participation. This is very important for us and for our societies to stay together. And I hope to see you very soon. And let's keep in touch. Thanks so much again.
Thank you very much.
Thanks.
Bye-bye.
Bye-bye.
Thank you.